Welcome to This Explainer. Today, we're unpacking a highly complex, honestly incredibly fascinating clinical challenge in advanced hepatology, and that is managing severe fluid buildup, or ascites, in patients with advanced cirrhosis. We're going to focus heavily on the mechanics, the risks, and the deep dive protocols of large volume paracentesis, or LVP. If you've ever found yourself wondering exactly how clinicians safely remove just massive amounts of fluid from a patient's abdomen while somehow keeping their entire circulatory system from completely collapsing, well, you're definitely in the right place. Okay, let's dive into this. Here is our roadmap. 1. Diagnosing refractory ascites. 2. Large volume paracentesis protocols. 3. Preventing complications with albumin. 4. Alternatives like pumps and catheters. And finally, 5. Definitive treatments with TIPS and transplant.
Part 1. Diagnosing refractory ascites.
To really set the stage here, we have to properly define the overarching clinical problem we're actually trying to solve. For about 90% of cirrhosis patients who develop ascites, the fluid can be successfully mobilized. Usually, it's through a strict dietary sodium restriction, capped at about 2,000 milligrams a day, paired with your standard oral diuretics. But this explainer? We're not talking about them. We are focusing entirely on the critical 10% who develop stubborn refractory ascites. This means their fluid accumulation persists or it rapidly recurs, despite optimized maximum tolerated doses of diuretics.
But here's the catch. Before a doctor can officially slap that refractory label on a patient's ascites, we have to prove they aren't just, sneaking salt. We distinguish between dietary noncompliance and true diuretic resistance using a really simple random urine sodium to potassium ratio. If the urine sodium is greater than potassium, hey, the diuretics are actually doing their job excreting salt. So if they aren't losing weight, it's highly likely they're just consuming excess dietary sodium. But if the urine sodium is less than the potassium, that points to true diuretic resistance. So why does this matter? Because true resistance means the liver disease has genuinely progressed, causing marked neurohumoral activation. The patient's sympathetic and renin-angiotensin-aldosterone systems are essentially just hoarding sodium.
Part 2. Large volume paracentesis protocols. Once we confirm the ascites is truly refractory, we have to intervene, and the primary immediate go-to treatment is large volume paracentesis. 8 liters. That's the typical amount of fluid a patient who's excreting almost zero sodium in their urine might require removed every 2 weeks just to keep up. To put that into perspective, that's the physical equivalent of 4 2-liter soda bottles of fluid physically tapped and drained from the peritoneal cavity, often using precise ultrasound guidance for safety, on a highly regular schedule. That is an enormous mechanical shift for the human body.
And this brilliantly illustrates why this procedure is so vital. Clearing a tense, completely fluid-filled abdomen offers immediate, profound relief. It ameliorates shortness of breath, relieves that awful gastric compression that makes patients feel full after just a few bites of food, and it even decreases intravaricose pressure, which can actually lower the risk of dangerous variceal bleeding. But we don't just dump all that fluid. Every single time we perform a TAP, routine fluid tests, specifically a cell count and differential, have to be sent off to rule out spontaneous bacterial peritonitis, or SBP. Part 3. Preventing complications with albumin.
Now, obviously, removing 8 liters of fluid rapidly isn't without risk. LVP is highly effective, sure, but it requires extreme precision to maintain safety. The hidden danger we're constantly fighting against is post-paracentesis circulatory dysfunction, or PPCD. When you remove massive volumes of fluid, it can cause a dramatic drop in effective intravascular volume. The patient's circulatory system scrambles to compensate, which ultimately leads to impaired kidney function that silently kicks in 24 to 48 hours later. Put simply, if we just drain the fluid and call it a day, we risk throwing the patient into acute renal failure.
So how do we combat this? With a highly specific, honestly heroic protocol. If an LVP removes more than 5 liters of acidic fluid, the absolute standard of care is to administer an IV albumin solution. Specifically, we infuse 6 to 8 grams of albumin for every single liter of fluid removed. This acts as a volume expander, keeping the fluid inside the blood vessels where it actually belongs, keeping the whole circulatory system stable. Let's look at how this builds out in clinical practice, because you don't just grab any albumin off the shelf. In the US, you generally choose between a 25% solution and a 5% solution. The 25% is your standard choice for a typical hypervolumic patient. Why? Because while both are isotonic, the 5% solution actually provides 5 times the sodium load of the 25%. We really only reach for the 5% solution if we suspect the patient is actively dehydrated.
Now, what's really interesting here is the staggering difference this makes. In randomized trials of patients with 10 ascites undergoing LVP, 21% suffered kidney impairment when they didn't get albumin, but with the albumin protocol, that plummets to just 2%. It's a spectacularly effective, highly protective intervention.
Part 4. Alternatives. Pumps and catheters.
While serial LVPs are the mainstay, let's be real, coming into a clinic every 2 weeks to have 8 liters of fluid drained is exhausting. What happens when patients need or just want an alternative mechanical solution? Well, one fascinating newer option that recently gained regulatory approval in the US is the automated low-flow ascites pump. This is exactly what it sounds like. It's a surgically implanted device that continuously pumps ascites from the peritoneal cavity straight into the bladder, meaning the patient literally pees out the excess abdominal fluid right along with their normal urine. It's an incredible workaround that vastly improves quality of life. But because there's foreign hardware sitting in the abdomen, they have to take daily prophylactic oral antibiotics as long as the pump is in place to prevent severe infections. When we compare that pump to a traditional palliative drain, the clinical considerations really come into focus. While the pump improves quality of life for folks who aren't eligible for TIPS, it comes with massive risks. In trials, patients with the pump had an 85% serious adverse event rate, mostly kidney and urinary infections. On the flip side, we have indwelling peritoneal catheters, palliative drains. These are strictly recommended only for patients with palliative goals of care. And for safety, those patients should only drain a maximum of 1 liter every other day, because draining more is strongly associated with increased complications.
Part 5. Definitive treatments, tips, and transplant.
At the end of the day, all of this, the LVPs, the albumin, the pumps, is essentially just symptom management. So here is our ultimate clinical algorithm for advanced cirrhosis. Step 1 is always evaluating for a liver transplant. Because patients can decline rapidly, we list eligible patients for transplant first. Step 2, if there are no contraindications, we look at placing a TIPS, a transjugular intrahepatic portosystemic shunt. But there is a huge caveat here. We generally only do this if their MELD score is less than 18, because a higher score sharply increases the 30-day mortality risk post-procedure. Only after exploring those 2 avenues do we settle on step 3, which is utilizing serial LVPs or pumps indefinitely. And remember, we list for transplant before placing a TIPS just in case the TIPS procedure itself causes their liver function to fail even further.
So the crucial point is this. Why push so incredibly hard for a transplant or TIPS? Because without a transplant, patients battling diuretic-resistant refractory ascites face a genuinely grim 50% survival rate at just 6 months. That's right, 50%. It drops to 25% at 1 year. That is a highly aggressive mortality rate. And for those who are eligible, placing a TIP shunt isn't just more effective at keeping the fluid away than serial LVPs, it actually improves overall transplant-free survival over time. Which leaves us here. Managing refractory ascites isn't just about draining fluid. It is a clinical tightrope walk. We are constantly trying to balance the immediate massive symptom relief of these heroic LVPs with the ticking clock of finding a long-term cure. The protocols are complex, the sheer mechanics of removing that much fluid are astonishing, and the sticks are quite literally life and death. It truly highlights the unbelievable challenges we face in advanced hepatology. Thank you so much for joining me for this explainer. I really hope it gave you a fresh perspective on this absolutely vital medical procedure.